This, I just wanted to see it. Thanks, you want to switch it on? Sure. Murder. So while this thing started, I know we talked, we was all virtual. So it's my first time doing that like this. So I'm just gonna be honest. But since we talked, there's a fast because we did 6 o'clock somewhere else, pushing almost the other. So I'm gonna make that kind of short, but without Roger being here, I think that may just gonna be shorter. So we go through video introductions and everybody. That's a bit of a movie about this put up country flag on this side. And then, so we've done some of the intros. Actually, brother, you know what? If you can leave that, I'll use that to do the intros, and then I'll come and sit back here. Thank you. Let's do the bios and everything. Come back and discuss the total stuff, but get to know you, type thing, and then we'll start going into some of the topics. We're not going to get to all the questions, actually, but it's turning out to be printed stuff just in case technology. Good afternoon, church. All right, good afternoon. Good afternoon to the Cyber Sanctuary, those who are online. Thank you for joining us for our health panel discussion, a minority perspective. So before we get started, I introduce our panelists up here today. Brother Tiffany Martinez, the son of one of our panelists, is going to come up and open up with a word of prayer.
Good afternoon. We thank you for all of you for coming here. Dear Jesus, thank you for this Sabbath day. Thank you for protecting us. Thank you for all the hope, kindness, and love. Please watch over us where we are, what time it is, and when we are. In Jesus' name I pray, amen.
Thank you, brother. Brave young man. Okay, so this afternoon we have three doctors here. I will be doing the panel, I'll be moderating the panel discussion. So we're going to get started first by introducing each person. Then we'll just go through some get-to-know-you questions with them. Then we'll get into the medical stuff. And then there will be opportunities for those in the audience and or online to submit questions, so we can then use the time wisely to kind of hopefully cover some things that you may be wondering about that didn't come up in the panel discussion. So we can get started. All right, so our first panelist is Dr. Desir. He is a board-certified specialist in sports medicine and general orthopedics. He graduated from the Ohio State University with honors and a Bachelor's of Science in Biology and a minor in musicology. He completed his medical degree at The Ohio State University College of Medicine. After graduating medical school, Dr. Desir completed a residency at the University of Miami-Jackson Memorial Hospital in Miami, Florida, where he served as chief resident. During his education, he gained valuable experience working as a team physician with the University of Miami Athletics, covering college-age sporting events, the Miami Sailing World Cup Regatta, various local high schools, sporting events, and treating complex musculoskeletal injuries. Following residency, Dr. Desir completed a fellowship in sports medicine with Atrium Health at Ortho, Carolina. During his training, he additionally covered many sporting events, working with several high schools, colleges, and professional athletes. He was the event physician for the Charlotte Marathon, Charlotte Golden Gloves Boxing Tournament, Women's NCAA Basketball Tournament, and CIAA Basketball Tournament. Since completing his training, Dr. Desir has participated in continuing medical education and remains current with most contemporary and advanced treatments and procedures in sports medicine. He has done extensive training in ultrasound and ultrasound-guided injections and applies his traditional as well as the most contemporary regenerative musculoskeletal treatment. Dr. Desir maintains memberships with the American Medical Association, the American Medical Society in Sports Medicine, the American College of Sports Medicine, the American Academy of Family Physicians, American Board of Family Medicine, and the Mortar Board Honor Society. Dr. Maykel Desir is of Haitian descent. All right, let's give it up for Dr. Desir. And Dr. Desir actually attends court. Our next physician is Dr. Jade Gittens-Hebron, DPM. She is a podiatrist located in Somerset, New Jersey. With her advanced training in all aspects of foot and ankle care, board-certified podiatrist Jade Gittens, DPM, can treat minor to complex conditions. She welcomes new as well as current patients to Premier Foot and Ankle Center located in Somerset, New Jersey. Dr. Gittens completed her undergraduate degree in the honors program from Montclair State University in Jersey. She majored in biology, minored in chemistry. Dr. Gittens was accepted into the New York College of Podiatric Medicine, where she earned her Doctor of Podiatric Medicine degree. While she was going through her podiatric medicine and surgery residency at St. Barnabas Medical Center in Livingston, Dr. Gittens served as chief resident during her last year. She was even the recipient of the prestigious Department of Surgery Mahmoud Chima MD Outstanding Resident Award. Dr. Gittens board certified through the American Board of Podiatric Medicine, as well as the American Board of Foot and Ankle Surgery. She also has a diplomate in the American College of Foot and Ankle Surgeons. Through her training, Dr. Gittens has gained extensive experience in the latest minimally invasive techniques in foot and ankle surgery and comprehensive diabetic palliative care. Patients of Dr. Gittens commend her friendly, caring demeanor. Dr. Gittens adopts a patient-centric healthcare model where she educates her patients and works together with them to tailor an optimal path to healing. She thoroughly provides information on diagnostic approaches, effective therapies, and if needed, surgical repair. Dr. Gittens offers same-day appointments and ensures all patients get back to 100% as quickly as possible without sacrificing quality of care. She regularly treats families and patients of all ages, including athletes and children. Dr. Jade Gittens is of Trinidadian heritage. All right, next up is another one of our local doctors from Kodo, Dr. Tiffany Martinez. She was born in Newark, New Jersey and raised in Irvington. She's the daughter of two God-fearing parents who emigrated from the beautiful island of Jamaica. She attended Columbia High School in Maplewood and Rutgers University in New Brunswick. She is a graduate of the University of Medicine and Dentistry, Osteopathic Medicine, and completed her residency training at Newark Bethesda Medical Center. Dr. Tiffany Martinez is a wife, mother to a blended family of 5, and most importantly, a woman of God. She is a board-certified obstetrician, gynecologist, and entrepreneur. Dr. Martinez has served as both the Director of Labor and Delivery and the interim chair of the Women's Health Department at Overlook Medical Center, improving quality and safety with a focus on driving down the Black maternal mortality rate. She currently provides obstetrical services through hospital-based work, caring for women in their most vulnerable moments in the Middlesex County area. She is the founder and CEO of OBGYN Board Prep Coach, where she empowers young women physicians of color to pass their oral boards and design a career they love. She is also a certified business, money, and mindset coach, helping women scale businesses to 6 figures and beyond. Dr. Martinez and her family are debt-free using the Dave Ramsey baby steps as of 2020 and paid off $439,677.42 in 5 years, to be exact. Because of this blessing, they're intentional givers, setting aside percentages of their income to support people and organizations in need. Philanthropy is one of the many things that Dr. Martinez wants to be really good at. Dr. Martinez volunteers her time to young aspiring physicians and has mentored 3 individuals into medical school, 2 of which were members of Church of the Oranges. Her favorite Bible passage is that of Mark 9:17-24. It's the story of the man whose demon-possessed son could not be held by disciples. When Jesus inquires about the son, the man says, "If you can do anything, take pity on us and help us." Jesus replies, "Anything is possible for one who believes." The man exclaims, "I do believe, but help me, Lord, with my unbelief." She feels this story embodies the thoughts of many of us, young Black women throughout the U.S. and abroad. Her hope is to continue to use God's blessings to pour into those around her. Dr. Martinez. All right. And I am your moderator, Dr. Clyde Griffith. I too, like Jade, went to Montclair State University. In fact, that's where I met my lifelong friend Jade, Dr. Gittens. I also went to New York College of Podiatric Medicine, where I completed a 3-year residency after that at the VA hospital right up the road from here. Following that, I transitioned to educational career, where I have a master's in educational leadership, and currently I serve as a district administrator with the Plainfield Board of Education in science and STEM, and I'm instrumental in operating all of our allied health services and science classrooms in that district. So, also a product of Church of the Oranges. So, we'll just move over to the table here and get started. All right, so, you know, it's a lot of times when folks go to the doctor, one of the first things they get is something we call white coat hypertension, where you start, I don't have that right now, I'm just sweating. You have white coat hypertension because it's the unknown, right? You go into the office, you may or may not have hypertension, but a lot of times, just by the nature, the anxiety causes that adrenaline rush. So I think we should take a pause today before we get into some heavy medical topics to just go around the table and just have a quick friendly discussion with our doctors before we move into some of the questions that I've prepared for discussion with them. So we'll do this round robin style, panelists. Can you briefly describe, we'll start with you, Dr. Gittens, you're the guest here, so we'll start with you. Can you briefly describe your thought process on your educational and professional journey into the field of medicine that you pursued?
You know, I guess growing up, I always knew I wanted to be in the medical field. I have memories as far back as, you know, being 4 or 5 years old, writing that down, stuff that my mom saved. So I always knew that. I was always geared, my mind was always there, you know, my trajectory through, you know, high school and in regards to knowing that I wanted to go be somewhere where that would allow me to kind of get into that next step, which is why I ended up selecting to go to Montclair State University. They had a health careers program, and at the time I had gotten a full ride there as well. And so it was just the progression of deciding which route I wanted to go, and just having the experiences of, you know, while we were at Montclair, you know, we were fortunate to meet a lot of different types of doctors, and even becoming a podiatrist, Clyde played a role in that, just because I wasn't really familiar with the field as much, and so he was shadowing a podiatrist, and I was able to learn about, you know, what they did, and I started shadowing a podiatrist myself. He was shadowing one, and I was like, maybe that's something I should find out about. And so, you know, so that was the course of it all, but I'm on track with the question. But yes, so it was always something, I always had that drive in regards to knowing that I wanted it. So it was almost kind of instinctual, it was always there.
Okay. Yeah, and again, it was part of the Health Careers Program, and this month is Black History Month. And part of us, we just don't want to educate folks about medicine, but the path that you took to get there, and that's why we're asking these questions. Dr. Desir, what about you? I mean, I talked about it in your bio, but can you just give me a little bit of what I didn't share in there? Like, how did you get into this path of medicine, and precisely on sports medicine?
Yeah, so part of the bio, you mentioned that I'm Haitian, all right? So for the Haitians that are in the audience and watching on the stream, as you know, there's 3 pillars in every Haitian household. We call it l'école, la caille, l'église. That means school, home, and church. So with the school aspect of things, you know, my parents, you know, they both came in their 20s here to America with nothing, right? And they worked very hard to establish some sort of foundation for myself and my little brother, and pushed us very hard. You know, you couldn't come home with anything less than an A, right? You come home with a 93, you know, my mom would get at me for why didn't I get a 98? If there's someone else in the class that can do that, you should be able to do it too. So education was always something that they pushed on us. When I was about 11 years old, my mom bought me a book called Gifted Hands. Many of you guys may be familiar with that. The author is Dr. Ben Carson, who, you know, after reading that book was a huge inspiration to me. After seeing what he's done politically, I don't know so much anymore, but You know, his life story definitely motivated me. And when I saw where he came from, I said, you know, if he can do it, so can I. From that point, I knew I wanted to be a physician. There were different internships I did in high school that showed me what it would take to actually go through the whole pathway to become a doctor. After seeing how difficult it would be, it actually motivated me even more because on the flip side, I also was very big into sports. And, you know, any of you guys that are athletes here know that athletes love a challenge. So to be able to, you know, grow in my journey in medicine and actually find a field that combined medicine with sports was like a match made in heaven. So I would say definitely, you know, the tutelage from my parents pushing myself and my brothers to do well educationally, that book showing me the field of medicine, and then all the different things through the path that actually helped prep me to be able to pursue a career in medicine, all what led to where we are now.
Thank you, Doc. Yeah, Gifted Hands and Think Big, those two books. I actually had the privilege at 13 years old of seeing Dr. Ben Carson speak live, albeit in the overflow room at CUC, now USC in Trinidad. And I remember it was a packed audience that day. Good. I know Dr. Martinez, you shared a lot, but is there anything else you didn't share? Just your journey into getting into OBGYN, and specifically, maybe the audience may not know this, talk about the DO, Doctor of Osteopathic Medicine, the philosophy of that, as opposed to medical, MD.
Absolutely. So I wanted to be a teacher when I was about 5 or 6. And my mother was a nurse, and she said, whatever you do, just don't be a nurse. Which everyone in my family is a nurse. So that was just her own disposition about it. But one thing I noticed, every time I went to my pediatrician, he always made me feel better. I don't know what that connection was. Even if I was getting a shot, I would leave there feeling better. And that was something that I wanted to give to someone else. And so when I went to medical school, in my mind, I was going to be a pediatrician. During that first rotation, a kid was pointing and screaming at me for no reason, and that kind of X'd that out. And I said, no, thank you. And I did my surgery rotations first, anything that put you in the operating room, because I knew I was never going to be in the operating room. And the moment I walked in there, I knew that's where I belonged. In terms of osteopathic medicine, I had not heard of it until I went to a fair at school. And so when you go the path of traditional medicine, there are 2 ways to get there, MD and DO. And an MD, we say allopathic medicine, and DO, osteopathic medicine. DO, really, the philosophy was born out of the fact that we are trying to restore your health, and that the body is one unit, and if you restore the main health, all other things will fall in line. When you really look at it, that is what most physicians want to do, but this was ingrained into the birth and the philosophy of osteopathic medicine. So we have all the same fellowships and specialties as allopathic medicine, and even now it's merging more. I don't even think they're differentiating it in residency the way they did in the past. But when I spoke to someone who represented a DO school and told me the philosophy, again, it clicked like, that is what I want to do. I believe from my own experience, when you have these thoughts and ideas and visions, at least of going into medicine, those are things that are placed in you by God. And so you really can't, you can fight on it, but it's something that you are going to do and continue to pursue because they were placed in you for a reason.
All right. So I know, obviously, Tiffany, your family's here. Jade, I know you have a young one. Dr. Desir, I know you have a young one. So just each of you quickly, how do you balance family life and a hectic work schedule? Start with Jade. Dr. Gittens-Hebron, sorry.
Well, it's hard. You know, I think, you know, you have this desire to be the best at everything, and you want to succeed, and you are trying to be the best doctor you can be, the best wife, the best mom. You know, but at the end of the day, I think obviously faith, prayer, and just trying to find, you know, having supportive family. You know, I have a very supportive husband, gratefully, you know, and family around that are able to kind of help and balance things out. You know, I have my own practice. You know, I run my own practice as well. So just trying to, I think at times the sacrifice becomes yourself, but just learning self-care. Just trying to force yourself at times to have that monthly massage or just take that time to go catch up with a friend and things like that. You almost have to become very strategic in planning of your life in order to really be able to try to balance it all, you know. So I'm no expert, but I think, you know, some months you feel like you're killing it, and other months you're overwhelmed. And, you know, you just take it day by day. Like I said, faith, prayer, and every day's a new day.
All right, so let's just marinate on that for just a quick second. Now, you speak about your own practice. I've been there. Right now I'm wearing some orthotics, which, thank God, they helped me, that you actually made for me, prescribed for me, actually. So just quickly tell me, I know you're with your mom's background, and how was it as a woman starting your own business, and how instrumental was your mom in helping with that, in that regard? And just let's talk about it real quick.
My initial goal was not to start my own practice. That was not a goal. My goal was to graduate, finish residency, go work for someone. It'd be, you know, this happy situation. I'll buy in, become partner in a couple of years, and that was going to be it. But that didn't work out, which was probably one of an early roadblock in my professional career. I was miserable at the first place that I worked at. And so having to kind of transition and pivot and figure out what to do. And it was really a conversation that I had with a primary care doctor who was actually taking care of my uncle at the time. And he was asking me how things were going. And he said, you know, why don't you just start your own practice? And I was like, in my mind, I was thinking, like, that's a lot of work. Why would I want to do that? That's hard. And so, but I didn't want to say that, but I was thinking that to myself. But anyway, I kind of went home and just, like, really thought about it. And I was like, I'm not really, in regards to what I want, I don't think I'll be able to practice the way that I want based on, like, the doctors that I had been interviewing with and just some of my experiences. And so it was really a conversation with my mom, who, you know, I was raised in a single-parent home. You know, my mom's from Trinidad. She moved here when she was in her 20s, same, you know, worked hard, you know, was very successful. And, you know, to her, nothing was impossible. It was like, what do you mean you think it's too hard? We can do it. And even when I wasn't sure, she went and started making phone calls, like almost I was upset with her. But she started, you know, calling people and asking about, like, renting space and all these different things. And so it just seemed like things just kind of were lining themselves up, and it was almost like I was saying, yes, like, this is what I want you to do. I kept saying reasons of why I couldn't, and so, so you know, that was how I got into starting my practice. And gratefully, I had a resident who was a year ahead of me, and he started his own practice 10 months before me, so he was extremely helpful in regards to just guiding me. Where do you get this? Where do you do this? Like, it just seemed like everything just lined itself and worked out. And so that was God, really and truly. And so here I am now, 11 years later with my practice. Started from scratch, you know, and so I'm very grateful. I am.
Yeah, and expanding. I have to come see the new place. I haven't been there yet. Dr. Desir?
Yeah, so finding work-life balance is tough. It's definitely a challenge. I feel like, you know, I know your question was based on with a family, but ever since undergrad, right, work-life balance has been difficult because there's a lot of sacrifices you have to make to be able to get to your goal. And it kind of escalated with each level, right? And now as an attending, you know, with a family, even though my work hours are a lot better than they were in my residency and my fellowship, the work never stops, right? You leave the job and you get home and your real job starts, right? I have a wife, I have a kid that, you know, I have to take care of. So I think one of the things that makes that a little bit easier is having a very supportive partner. So my wife is extremely helpful in everything that she does at home. But then also, you know, my son, he's 14 months old. It's my first child, so, you know, it's my first experience in fatherhood. So when you come home and see the child with the smile right across his face running to you, you know, who cares about work-life balance at that point, right? So even though, you know, it's a lot of work that has to go into taking care of him, it's all a blessing, and it actually energizes me. So I actually think family has been a positive. So my work-life balance, at least how I perceive it mentally, has actually gotten better, right, since having my wife and my son, because I have something to look forward to do after work. The other thing is, as you mentioned, you know, I'm in sports medicine, so there's a lot of different capacities that you can work in sports medicine. A lot of my fellowship time was based in covering a lot of those various teams in Charlotte, North Carolina. So, you know, there's a lot of traveling. You know, there were days where I was getting to clinic at 7 o'clock in the morning. Then after clinic, I have to go to the training room to go evaluate some of the athletes. Then after the training room, go to some games to cover games. So I'm getting to work at 7 in the morning, getting back home at 10, have to rinse and repeat and do the same thing the next day, right? So one of the things that I did coming into attending SHIP is now I primarily just work in outpatient private practice, where I'm not actually covering any games or any teams right now. Initially I wanted to eventually get back to covering teams, get back to academia. But after having a family, I recognized, you know, how good of a system, you know, that I had going on with that. So sometimes in medicine, you have to just really structure, you know, your everyday in terms of, you know, what you're doing with your job, and not choosing to put too much on your plate when you know you have another responsibility, which I'd say is actually a more important responsibility, which is my family.
Thank you. And actually, as you say covering, I was walking down the aisle and I saw covering physician for today at Church of the Oranges, Dr. Maykel, on the medical room. So you come to church and you still got your covering, brother.
That's like the work never stops.
Labor of love. All right, Dr. Martinez.
Yes, so I would say that as I progress in age, right, and having the experience of mainly working for other people, right, so private practice, I've looked at it in the same way, like, oh, that's too difficult, and I've worked in private practice for one other person. I went to a larger group, worked for, you know, a hospital, then a bigger system. Pretty much what I do now is if it's threatening my happiness, I just quit. I just quit, right? Like, and I was talking about this even with Elder Lavelle and Renee just right before this. I just quit. Now I have a plan when I quit, but I realize that I don't have to do anything that I don't want to do. And thank God for the Sabbath, right? Because if it wasn't there, I would really be working 24 hours a day, 7 days a week, right? I think many of us can relate that we are, whether you realize it or not, a lot of us are addicted to hard work, right? Like, we'll say we're tired, we'll say and then we just keep on, and you'll get in a better spot, and then you add some more. And so I had to really start to realize the situations that I was putting myself into, and I had to be intentional and strategic. And for me, my family and church support is everything. I planned the birth of my first child around my father moving 5 minutes away, right? Like, I was like, I need somebody to watch my son. We're packing your things, you're coming to live near me, and you're gonna help, right? And then when that once my second little one came along and that was a little bit too much for him, I hired an au pair, which I didn't know what an au pair was until I worked with other physicians. This is a person who comes here on a J-1 visa through a government program, and they live with you for 1 to 2 years, and they usually come from somewhere else in the country, another country, with the intention that you incorporate their culture into your home and vice versa. And so I have an au pair here now for 1 year and 7 months. She's like another, I have adult children, so she's like another adult child who helps me with the little ones during the day. So my father, having an au pair, coming to church, even now, right? My husband is not here. He'll be running in and out. He might be with the kids more than I am. I can't really tell. So he's extremely supportive in that aspect. And when I come to church, I know that Martha can sit. Yeah, Christian's raising his hand. Martha will sit with my son, Renee. I have so many friends here like, oh, will you watch him while I do X, Y, and Z? So the support, the intention, and understanding that you actually have control over your life and making those decisions for yourself.
Thank you. Okay, so hopefully that kind of breaks it down for any young people either on online or in the audience who are contemplating a medical career. You've gotten a little background on 3 different specialties here. Now we're going to get into some of the heavier topics, right, what you guys came out here for. So let's start with one of the major complications in our black communities, diabetes. I'll start with, let me kick this off with Dr. Desir. In your practice, where you work in Staten Island, do you see any correlation between some of the pathologies walk into your office and diabetes, and if so, how so?
Yeah, so, diabetes obviously is a chronic disorder that affects a large portion of just the general population, in general, but also people that look like us, right? And there are some things in the realm of sports medicine, some pathology that actually you have a higher incidence or higher risk of developing if you are diabetic. A couple of things. So one is something called frozen shoulder. I don't know if anyone in the congregation or anyone watching on the stream has ever been diagnosed with frozen shoulder. What that is something called a capsulitis. Anytime you hear the word itis, that's inflammation. So the capsule around the shoulder gets inflamed. And what that does, it limits your range of motion with reaching above your head, across your body, behind your back, but it also can cause a lot of pain too. So if anybody has, been developing, those symptoms, especially slowly over time, because again, it's called frozen shoulder, so there's a freezing period, right? It usually happens over the series of a few months, right? And then there's a thaw-out period that you have to have where you do physical therapy, different injections we can provide, different, other things that we can do to try to help resolve the issue. If you're a diabetic, you're at a higher risk of developing something like that. Another diagnosis that tends to correlate a lot with diabetics is something called trigger finger. So if anyone has ever had a situation where their finger, right at the knuckle, right in the middle of your fingers here, your finger just gets stuck and you have to pull that finger back up, or you feel clicking there, or you have pain in the palms of your hands, that's actually something that, diabetics actually have a higher incidence or a higher rate of developing that type of disease, which is also an interesting thing to treat. A lot of times if you go to the doctor's office, they'll order something like a cortisone shot or a steroid injection to help decrease that inflammation, to help with the inflammation that's causing the problem. The issue is with the diabetic, steroids actually increase your blood sugar. So it becomes very important that you're actually managing your diabetes very well, so that if a treatment like that is offered, it can be administered safely to help resolve the musculoskeletal issue. So I'll say frozen shoulder and trigger finger are 2 of the big ones.
Okay, thank you. Dr. Martinez?
So I mainly manage and diagnose diabetes in pregnancy. And it's hard. So we believe when you become diabetic in pregnancy, it's mainly from the placenta. Would I say that it's at increased rate in the black population? I'm going to say yes. And that is a whole nother conversation about why, right? Because you can have someone who is, a vegan, who exercises every day, and still be affected in that manner. So that's a whole nother theoretical conversation. But it is prevalent. Diabetes is something that I love to let people know. It is the one disease that you can actually manage and your body not believe that it's diabetic, right? Like, it's the one disease that has that capability. And so through exercise, diet, and of course medications, we can manage diabetes. And it's something that you really want to get control over during pregnancy, because it has long-lasting effects on not just you, but also your unborn child. So yes, it is present. It is something that we work on, but I look at it as one of the diagnoses that that can have a happier ending.
I agree, and I was actually having a conversation with a physician about this once, and he said something, which is, he's like, it's the one disease where you actually called, the patient is actually named after it. They say you're a diabetic. No one says you're a hypertensive or you're a cancer. They say you have hypertension, or you have cancer, or you suffer with gastroesophageal disease. This one, they actually tell you you are a diabetic. So it's almost like you're claiming it. But it is one, yeah, you're right, that it is treatable. However, there are instances where folks do need to be on medications to manage it. but definitely it is one of the treatable diseases. And brings me now to Dr. Gittens-Hebron. I saved you for last because I know the diabetic population, foot and ankle pedal problems are very prevalent. It's one of the first places that after neuropathy, well, I'll let you go. I don't want to steal your thunder because as a podiatrist too, I could just go to town. So you go ahead.
Yeah, let me try to. So, right, diabetes is very prevalent in what I see. And I'll start. It starts as from the initial, when the patient comes in and you know, you're going through the medical assistants in the room with them, and they're going through their medication list, or they're doing their intake in regards to it, and the patient either A, doesn't realize they're on diabetes medication, or they're like, I'm not diabetic, but you're on diabetes medication. Like, patient education about diabetes is just mind-blowing to me. Patients not being on medicine and not knowing or understanding the numbers of where they should be, understanding what their A1C is, not understanding that the reason why a lot of the complications that they may be dealing with is related to the fact that their A1C is elevated, not understanding that sometimes the answer is you have to get your A1C down. And so that's one of the biggest things I see in regards to it. It's just that's frustrating to me, is I just see so many patients that just don't understand diabetes and what it does to them, the complications of that. And so we know with diabetic patients, especially when it comes to their feet, right, they're at increased risk for a lot of other things. A lot of our diabetics have a lot of other comorbidities, right? And so they, in regards to hypertension, they may have some type of cardiovascular disease. And all of these things play a factor in regards to being able to try to treat them and heal them and get them better. And so we know, right, diabetic foot neuropathy is a common complication of diabetes that we see. It's complex in regards to treating it. There is no cure for it. We're really trying to manage the symptoms. And again, getting that A1C under control, that's really the number one priority, not medications, not medications to treat the numbness, meaning that let's getting this diabetes under control with your diet, with your exercise, and taking your diabetes medications. And so, we know those complications that when we don't see patients taking care of themselves, they end up with diabetic foot amputations. We're talking about patients in their 30s I'm doing diabetic foot amputations on. They're just not taking care of themselves. They're not taking their meds. They really just don't seem to understand diabetes and what it does. I find is the common thing, is that I just feel like we end up spending time trying to do diabetic education on these patients because they just really don't know and understand. And this isn't people in their 30s, 40s, 50s. This is not, and it is more so in the minority population, So yeah, there's a lot of complications that we see in regards to it. A lot of what, some of what we try to do is preventative, obviously, in regards to preventative routine foot care and things like that, right? We'd rather be proactive than reactive. So, in regards to those things. But yeah, just in general, healing, right? Healing of wounds that a patient may have on their feet. Just healing of their body when they have these things. When your diabetes is not under control, it affects the whole healing process. So, yes, diabetes is a big factor of a lot of the patients that I see daily.
Right, and education-wise, Dr. Gittens hit it on the head. Education is important because A1C levels. So A1C, you heard us say that, it's really your hemoglobin A1C. Hemoglobin is the pigment the pigment gives blood its red color. But there's a particular protein called A1C that is marked or linked to elevated levels of blood sugar or blood glucose. And when you look at it being between 4 to 6 is normal. Once you get over 6, it becomes elevated. Years and years and years ago, the nurses here who in the audience and medical professionals can attest, before this became a thing, they used to have to find it in the blood, in the urine. But usually, typically when you diagnose diabetes through urine, it was already in the system 10, 15 years before that. So we do have the technology now and the knowledge base to actually do the blood work early on and get these things under control early enough. And just sticking with that, diabetic neuropathy and cardiovascular disease, or let's say PVD and neuropathy, Dr. Gittens. Could you just get into those two things briefly so the audience understands what is diabetic neuropathy and what is PVD?
So diabetic neuropathy is loss of sensation, loss of protective sensation. And we know that with elevated blood sugars, the nerves basically become dysfunctional. They don't work properly, and patients can develop, some patients may have where they have pain from their neuropathy, to the opposite, where patients have no pain, they don't feel anything, but there lies the issue, is that they can have a wound or something on their bottom, on their foot, and they have no pain. So, right, pain is an initial indicator for a lot of us that something's wrong with our body. But when we don't have that sensation there, unfortunately, it allows wounds to become bigger, deeper. Because that's not there, and then it makes it a lot harder for them to heal. They're more likely to end up with diabetic foot amputations, again, because the infection has spread down to the bone. And so that the diabetic PVD also, or PAD ties in as well in regards to that, right? Because in order for wounds to heal, you need blood flow. And so when the blood isn't there, right, so you have a storm here where you have no blood flow and you have no sensation to the feet, it makes it very hard for these wounds to heal, which can lead to a lot of times. We know the statistics in regards to when a patient loses one toe, and you keep cutting in regards to, leading up to below-knee amputations and what the life expectancy is for these patients. So, they tie in together, and that's really, again, one of the biggest one of the hardest things that we see in regards to is really trying to get these diabetic wounds to heal by controlling their blood sugars, by trying to restore their circulation if they need referring them to a vascular surgeon if they need revascularization, meaning that the circulation is just not coming down to their feet. It just stops. The vessels become calcified or hardened in regards to that. So it's very complex, and most of the time it does take a team aspect of trying to get these patients to heal, or trying to minimize how much that you may have to amputate based on, the wound.
Yeah, and in fact, that's very important, and when you mention a team effort, because one of the first things that one of my mentors, when I was actually shadowing when I was still in college, told me was, a foot doesn't walk into the door by itself. All right, so even though you're labeled or your degree is a podiatrist, that foot is connected to a body. And what's going on in there, the pathologies that happen in that foot are related to things that are stemming maybe from the heart or the brain, or in this case, blood glucose. And a lot of times, as doctors up here, we throw around terms, but PVD is peripheral vascular disease. And you heard Doc mention PAD, which is peripheral arterial disease. So pretty much when you have these foot ulcers that don't heal, you have a trifecta. You have a localized injury because they didn't feel it when it got stuck or when an insult happened to it. They have poor blood flow, and then just by virtue of having increased blood glucose levels, wound healing is compromised. So you're already starting on the back foot. And Dr. Gittens can tell you, when I was in residency, and when I'm sure in her residency as well, and even in practice, many times you can look at a patient's medical chart, their history, and you just know, yes, there is a God, but you can almost predict this person's going to end up with a mid-foot amputation or below-the-knee amputation just by seeing the visits, who they're going to see. One of the benefits of me working at the VA as a resident, I had the chance to talk with a lot of veterans, and these gentlemen, they can tell you some life stories, but they were ahead in terms of medical charting. So when I looked at the medical charts, I can go in and click around and see every single clinic they visited, and based on those notes, I knew what was going on with that person. So a lot of that does stem from having knowledge, a team-based approach, because understanding the patient and any comorbidities they may have that may cause them to become, sadly, a lifelong patient for a podiatrist. Let's talk hypertension for a little bit. Dr. Yes.
Just before we move on from the topic of diabetes, I know, so I'm a sports medicine physician, OB-GYN, podiatry, but just some general symptoms that the population can have from diabetes that can help you know whether or not you should get checked out or let you know that you're not really controlling your diabetes very well. So things like blurry vision, things like having excessive thirst, having to go to the bathroom a lot, all those things are symptoms that you're going to have before you really start developing, the foot ulcers, right? Before you develop the trigger finger or the frozen shoulder. Those are things that if you're finding that you're seeing increases, again, in excessive thirst, having to go to the bathroom all the time, blurry vision, things of that nature, especially if you have a family history of diabetes, those are all things that should be indicators that you should be going to your primary care doctor and getting a simple blood test, right? Because that can help you know whether or not you have diabetes, whether or not you're pre-diabetic, and there's a lot of lifestyle changes that you should be making. And if you've already been diagnosed, we know that if you're still having those symptoms, that some things need to be adjusted. So you should know what your numbers are so that we can avoid you having to get to the point of, having an osteomyelitis where you need, an amputation.
All right, well, you keep the mic, brother, because we'll start with hypertension. See, we ended with that. So can we start off with hypertension, and let's talk about some things that we know hypertension is a silent killer, right? So why is it given that term?
So the reason why it's given the term of being a silent killer is because a lot of patients, actually you touched on it in terms of diabetes also. So there's a lot of these chronic diseases where you can actually develop those diseases and not have symptoms at the time when you developed it, right? So if I have an elevated blood pressure for, let's say, 5 years, let's say, right? But let's say it was mildly elevated, right? Mildly on the elevated side. I never changed anything in my diet, never changed anything in terms of my exercise routine or anything of that nature. Gained a lot of weight, eating foods that are high in salt content, so now my blood pressure is gradually getting worse over that time. Well, over time, that perfusion or that blood flow to the different organs in the body becomes less and less and less, right? And over time, that chronic decrease in the blood flow to those different organs in the body tend to lead to the different types of organ dysfunction that you can get. So as many of you probably know, things like kidney disease, heart disease, stroke, right, to the brain, all those things are all related to this one concept of elevated blood pressure decreases blood flow to these different important organs in the body, and over time that could lead to these symptoms. So the reason why it is considered a silent killer is, there's this whole period of time that you could actually have that diagnosis and not know. And it's not until you start having some of these symptoms that you're, brought up to speed about what you actually have and what the diagnosis is. And sometimes, in a lot of cases, it's, doctors, if you're going to your general annual exams, they're going to catch it early on for you. So that's the importance in prevention. But let's say you're not doing that and you start to have those symptoms. Sometimes it's a little late, right? So we have to do a little bit more aggressive intervention other than just diet and exercise to try to get you back to normal, right? So that we can avoid any of those complications with the damage that's already been done to your organs.
And while we're on that topic, just similarly in the last question, do you find, even in sports medicine, are there any issues or pathologies or I should say comorbidities along with injuries that are affected or perhaps precipitated by hypertension?
Well, I would say a lot of the things that, in terms of the realm of sports, that deal with hypertension are whether or not athletes are able to participate in the sport based off of their blood pressures, right? And, a lot of athletes are young athletes, right? But there's a lot of supplements that they can be taking that may increase their blood pressure, a lot of things that they may take behind closed doors that can cause, a vasospasm, right? So your blood vessels constrict, which again decreases blood flow, right? That can raise the blood pressure. So there's a lot of different things that could make it unsafe for an athlete to get their heart rate up with an elevated blood pressure. But also, athletes aren't just young people, right? So if you go to any pickleball court, right? I don't know if you guys are familiar with pickleball around the country. It's a lot of individuals that are 50 plus, 65 plus that are playing that have these diagnoses already, right? There's a lot of individuals in their mid-30s or 40s that are newly diagnosed with high blood pressure, where these things can be, detrimental because, again, when you're working out, your body requires a higher volume of blood flow to these organs for it to operate properly. So if you already have a disease that's decreasing your ability to bring blood flow to those organs, and now you're doing an activity that requires an increased load, and you're unable to do that, that could lead to some significant issues.
Okay, good. So I'm going to address one more how should I put it, chronic, and I mean, obviously, any medical condition can be considered serious because once it affects your quality of life, it's serious to you. But let me go into one that is very prevalent in our African American community, which is breast cancer. Dr. Martinez, can you just talk briefly about screenings? Just go have at it. I'll let you just take the floor on that. Screening, prevention, curative perhaps, obviously not at the surgical level, but just talk about what can be done to educate our women more about the severity and prevalence of this scourge.
So the first thing that I like to make sure that people know is that the incidence of breast cancer is 1 in 8, which means if there are 8 women in the room, and I'll stick to women, men can get breast cancer as well, but it's much rarer. If there are 8 women in the room, 1 of them will get breast cancer. And so because I educate on that so often, anytime I'm in a room with 7 other women, I'm like, okay, make sure I'm, right? Like I'm always thinking of myself, make sure that I'm staying on top of my preventative screening. So you can begin screening for breast cancer as early as age 21, going in for your annual exam. And if you see a doctor before that age, just a simple breast exam once a year is one of the best ways to begin screening. We do recommend becoming familiar with your breast tissue, so not so much that hardcore every month, 15th of the month, in the shower, do that breast exam. I don't know, some of you may remember there were like things you hang up in the shower and you had to do this. We noticed that caused a little bit more anxiety and false positives, but being aware of your breast tissue. So from time to time, maybe once a month, once every 2 months, feeling the breast tissue and remembering that you have breast tissue underneath your armpit, right? So starting all the way under your arm and feeling every aspect and down to the nipple. When you are familiar with your breast tissue, then you are more likely to identify a lump or a mass or pain. And so that is the concept there, becoming familiar with the breast tissue. So at age 21, you're going to have your gynecologist do the breast exam. We're going to recommend that you become familiar with your breast tissue. And by age 40, there are many organizations that have different stands. I go with by age 40, you're going to have your first mammogram. Your mammogram is going to be an image done at a facility where we take several pictures of the breast tissue and make sure that we don't see anything that we need to follow up on. That mammogram should be performed yearly, and a conversation with your doctor will determine at what age you would like to stop doing those mammograms. Some organizations say 70, some say continue until, and so that would happen between both you and your physician. But the beauty of breast cancer, so I don't know if you notice, it's really everywhere. Like, breast cancer is everywhere. Anyone who you talk to will either have had breast cancer or know someone who has breast cancer. I have a cousin who, as a child, she actually went to this church as well. They later moved down to Florida. And we actually look more like sisters than cousins, me and her, in comparison to my other brother and sisters. And she just died of breast cancer, recurrence. And she was 52 years old. So, and that hit hard for me, especially because we look so much alike. But it is everywhere. The beauty of breast cancer is because it's everywhere and because we have done so much research in it, it is not the killer anymore. So lots of people will be diagnosed, but we screen better, we can treat it better, and we have so many people who survive from breast cancer.
While we're on the cancers, cervical cancer, can you address that briefly?
Cervical cancer, okay. So cervical cancer, which is cancer of the cervix is the opening to the uterus, right, where the baby comes out. Cervical cancer screening has changed over the years. We recommend pap smears in your doctor's office beginning at age 21. And if your pap smear is normal, we're gonna recommend it every 3 years until age 29, okay? You should see your GYN every single year, but they're only gonna do the pap smear every 3 years. Once you hit age 30, we do recommend it every 5 years until age 65. If you have an abnormal result, they're gonna recommend some screening that might be earlier or some additional testing. Cervical cancer is so important to me because I'm revisiting this topic. I don't know if anyone remembers Henrietta Lacks.
Absolutely.
right? And so this is a woman who was born in 1920 and died in 1951, a year after her fifth child, a year after her fifth child. And she was a black woman in the Maryland, D.C. area who went into the doctors knowing that something was wrong, and she could feel, like, she called it like a knot on her womb. And there was a mass on her cervix, it was diagnosed as cervical cancer. Well, she was so important because what the physicians did was they took a sample of this cancer. It looked different, there was something special about it. They took a sample without her knowing, put it in a petri dish to grow it, and she died in 1951, and her cells are still alive, and they continue to live. And any medical technology that you can think of is because of her cells that for some reason could still maintain growth, could still give us information, even though they weren't inside of her. Her cells contributed to the vaccines that we use, HPV vaccine, polio vaccine, contributed to IVF, like literally everything. And her cells continue to live on today and to help us with medical research. And the sad story is that she never knew that they took her cells. She never gave consent. She never benefited from anything, and neither did her family, up until recently. And so her family, it was an undisclosed amount, but her family, in her, representing her, can you imagine if that was someone else, how much money they would have had? Yep. Can you imagine? So her cells contributed so much to where we are today in such a good way. And she was never acknowledged for it. She never knew, they took advantage of her. And it's one of the sad, dark stories in medicine that I think needs to be continued to talked about more and more, because it's not the only isolated one. And we need to be, I think the saddest part is, like, if it helped so many people, how come so many people in her family couldn't even afford to see a doctor? Like, that was one of the statements that came out. Like, they didn't have, they weren't homeless, but they did not have health insurance. They did not seek medical attention. They had many chronic diseases that could not be treated. So yes, cervical cancer is very important to me.
Yep. Cancer, for those who may not know the nitty-gritty of it, it's rapidly dividing cells in a place that it's not supposed to be. And as those cells divide so rapidly, they tend to then cut off life to the tissue around it, and then thus debilitating either that portion of the tissue, or if it's in a serious enough place that it gets to the lymph nodes and it metastasizing, meaning it goes to seeds in different points of the body, affect different organs and eventually cause death. 2001, I was at Montclair State University doing molecular biology. You remember that class, Jade? I don't know if I was with you in that class, Dr. DiLorenzo. And I never forgot it. We were doing a lab. It's a 400-level class. And she brought out this bucket of fluid. And then we each had to pour the fluid into some trays. And we used the micropipettes. And on it said HeLa, H-E-L-A. I just asked, what's that? She's like, oh, those are stem cells. It took me 20-something years later to know that HeLa was actually Henrietta Lacks. So that young lady from 1920 who died in 1951, her stem cells were being used at a university in a lab. And what were we doing with it? We were doing research. We took chick embryos. We were taking chickens, growing them to a point where we can recognize the limb parts, sever the limbs, then put the limbs into Henrietta Lacks cell line to see if we can grow a chicken leg or a chicken wing. That's happening today in organ regenerative work using Henrietta Lacks cells. We know that cancers, the cells divide rapidly, but hers was so rapid. Fast forward, 2003, I graduated Montclair State. After a short stint working downtown in the state, I went and worked for a pharmaceutical company, Immunomedics, where we were developing, I was working in manufacturing, and then I was actually moved over to cell culture. Huge barrels, you know those barrels you ship stuff home with, the 55-gallon blue barrels? Barrels like that, filled with HeLa cell lines. At the time, I just knew it was stem. Oh, they just call it healer. I had no clue. Here I am, an African-American young man, the only one working in manufacturing. In fact, the only one in manufacturing and research and development. And we're taking these huge vats of stem cells into the lab to purify drugs for leukemia to be shipped to Europe for clinical trials. So we take about 10 barrels, that's 550 gallons of HeLa stem cells, purify it down to like 1.5 gallons of injectable material. So that's, I mean, you bring up a real good point there, Doc. Black History Month. In fact, last week I was upstairs with the Pathfinders and they were choosing topics, and my head rose when one student, one child chose Henrietta Lacks. I was like, wow, okay. So I think more research needs to be done on her, and there's actually a movie that came out, I believe it's called Immortal Life of Henrietta Lacks. I think Oprah Winfrey might have been in it. So it's something you guys can take a look at. It's very, even the young ones in here, you will really enjoy it. It's very educational, and I think just coming out organically in the conversation, it's just crazy how here I was 20-something years ago dealing with this in college and in work as a technician in a lab. And I just saw HeLa, and I asked, and they just said it's stem cell lines, and no one bothered to explain to me what it was. I just found that fascinating. All right, so let's move forward. Let's move off, switch gears a little bit from some of these heavier topics. High heels. Jade, Dr. Gittens. As a man, I'm going to step off of this one. How does the wearing of high heels in women cause issues in the feet? You can start with the feet and work the kinetic chain all the way up to the neck. Have at it. What are the benefits to wearing high heels besides cosmesis?
High heels. So I am not the podiatrist that tells women, oh, you should never wear heels, because that's not, well, but that's not, right? So it's that, but there's a big but to that.
There's more.
The but is understanding certain heels are only appropriate for certain times, understanding your foot type, that certain foot types are going to have more issues with it, right? So someone who may have a flatter foot is going to have issues more so with a bunion versus someone who has a normal arch, truthfully. You know, so again, about where you're going, what you're doing, how much time you're spending on your feet. If you're going out and you want to be cute and you want to put on your 4-inch heels, you know, and, you know, in regards to that, that's fine, but that can't be your everyday shoe, right? That just can't be. I mean, we know the effects of what they do. When you think about your foot and what it looks like, and then you look at the high heel, you do the math, like you look at it, it just doesn't match, right? And so what you're doing is you're putting abnormal stress on your feet, right? You're stressing the joints, you're stressing the tendons, the ligaments, and you're going to develop some chronic issues, you know, in regards to hammer toes and bunions and things like that. Those toes have nowhere to go, and so how it affects those joints, right? And yes, you can develop chronic pain, right? We also know that people who use a lot of high heels can develop issues as well, even with their Achilles as well. So there's a lot of complications, and most of the complications that happen, they're not simple solutions. A lot of times they may need some type of surgical intervention. Yes, sometimes you know, steroidal injections can benefit, but we have to be very mindful of our shoe wear for it to be appropriate for what we're doing. And the answer is if your feet hurt, then you shouldn't wear it. In regards, it sounds so simple, but if it's something that hurts your feet, you know, your normal everyday shoe that you use shouldn't hurt your feet. So, I mean, this is a very, you know, I'm being very generic in regards to this, but yes, you know, yes, a block heel is going to be better than a stiletto heel. A chunkier heel is going to be better than a stiletto heel. All of those things, you know, heels are not the enemy per se, you know, because for certain foot conditions, we prefer for a patient to be in something with a lift, the heel or wedge, than being very flat, right? Because being very, you know, it's like heels are so bad, right? And But flats can be just as bad in regards to the issues that they cause in regards to use of very flats of shoes. So, there's a time and place for certain shoes, and certain foot types can do certain things. So maybe one girl may be able to wear a shoe that someone isn't, and she's not in pain, she understands inherent risk, she wants to wear them, but there's long-term use of those things absolutely, though, can affect your body. It affects your back, it can affect a lot of other things just in regards to your feet. So it's like, buyer beware, understand, look at your family history, look at your your mom's feet, look at your grandma's feet, look at it to understand what your feet may potentially look like down the road in regards to that. So
while you're on that, you mentioned hammer toes and bunions. Briefly describe those two conditions, obviously not just from the perspective of shoe wear, but what exactly is a hammer toe, what is a bunion? And I know that's like bread and butter surgical correction that you do and that I did in residency, so talk about it.
So hammer toes are a contracture of the toes, and when we talk about the toes, there's joints, where the toes bend, and over time, some people can have mild bunions where they may be, mildly contracted, and then there's probably what more people tend to think of when they think of the hammer toe, very severely contracted. The toes may not bend, they may have corns on, the tops of their toes, right? Those are your traditional type of hammer toes, and then there's, bunions is when you talk about the foot on the inside part, right? That would be your bunion. Some people may have a bump there. And then you can also have a bump on the outside part, which is called a tailor's bunion or a bunionette. So again, shoe wear influences the effect of these things, right? And in regards to that, but are they the direct cause? They're definitely, I don't always say that, but they definitely influence the progression of these things. But again, genetic history does play a factor. So someone could wear proper supportive shoes and still develop bunions and hammer toes again if that's a part of their genetic history. So, they can cause some, now these things are not always symptomatic. Many people have bunions and hammer toes and they're asymptomatic. They may not like how they look, right? So really surgery is something to address in regards to those things. If they're symptomatic, I normally tell patients, I don't tell you you need surgery, you tell me. Meaning that, is it affecting your life? Is it affecting your ability to do the normal things that you like to do? The activities, in regards to that. So when they become that severe, after, conservative treatment, which, yes, means eliminating shoes that, that are putting pressure on those areas there, if the pain presents, then it becomes something more surgical. But yes, there's different severities of it, and so there's no one treatment for hammer toes and bunions. Certain treatments may be done for one versus another, and it depends, again, on the type of deformity that it may be. Are they flexible? Is it more rigid? Is it more stiff? So that's in general, but, shoe wear does play a factor. And again, very flat shoes are a big cause of a lot of these things that we see, especially in women, shoes without support, they just wreak havoc on the foot, they do, so.
So you don't suggest walking on barefoot?
Oh, another controversial topic.
We actually have a colleague that went to school with us that she's a huge proponent of barefoot.
Yeah, so no, I'm not a fan. Barefoot, again, you think about, yes, in certain countries and certain people, like, right, barefoot is norm, and that's what they did. And I'm almost to the point when I tell patients, if they're happy, they have no symptoms, and their feet are fine, and if you're comfortable with that, again, there's inherent risk with those things. But if you're coming in for certain foot issues, I can tell you majority of the time, eliminating being barefoot is a step one. I always tell patients, I can give you an injection, I can do this, I can do all these things, but really, you really have to eliminate barefoot walking. There's no support, there's no stability. Your feet are needing that increased support, and when you're barefoot, you don't have that, and it actually can make a lot of conditions worse. So I do not recommend barefoot walking, no.
Okay. Dr. Desir, tomorrow's the Super Bowl. Concussions. A large contingent of the players in the NFL, and as a result of the feeder programs, be it college, high school, Pop Warner, are minority. I think it's something like 70% of the NFL players are black. And I know you've had some experience working with Golden Gloves, boxing. The two professions are contact sports. Could you just speak to that briefly about concussions? Do you see any of that coming in? Obviously, I'm sure you probably see some from accidents, but do you see it in any young athletes, whether it's those two sports or our beloved soccer or football?
Yeah, so great question. All right. So I would say in the capacity that I work now, I don't see concussions as much as I did back in my training, so back in my fellowship. So my fellowship, the majority of the patients that I was seeing were, concussion patients. And I would say sports like boxing, sports like football, those are the popular ones that everybody knows can cause head trauma that can lead to, concussion-based injuries. But you asked a question about kids, and interestingly enough, there was a study that was done, I forgot what years it was done for, but it was over the span of about 15 years, where what they found was athletes between the ages of 9 and 18, the population that actually suffered the most concussions were actually girls soccer. And a lot of that had to do with neck musculature and doing head balls and things of that nature. But also the thing is to keep in mind, concussions aren't only caused by head trauma. All right, so essentially anything that can cause an injury to the brain. You mentioned car accidents, right? So in a car accident, it's not all the time in a car accident that you bump your head, right? But you still can have a concussion after. Anything that essentially rattles the brain, causes it to move around in the skull, and can cause that kind of damage or cause different shearing forces that can cause injury to the brain can lead to a concussion. I was looking up a stat the other day, and it said that there's about 3.8 million estimated concussions per year. And the interesting thing about that number is greater than 50% of concussions actually go undiagnosed. So that number of 3.8 million isn't even an accurate number, right? The number is probably way higher than that. And I think, the biggest thing with concussions is just in general, concussions usually resolve after about 7 to 10 days on average. And actually, when you look at the return to play protocols for concussion amongst athletes, the return to play protocol can be as fast as 6 days, right? Because there's 6 different steps that we have to take before we can clear an athlete to get back onto the field. Now, with the fact that the concussions take about 7 to 10 days, you can imagine if you had a concussion, let's say you play a contact sport, you have a concussion, but you hide it from your coach, or you don't really know whether or not you truly have a concussion. And before that concussion resolves, you have another impact that leads to another concussion. That's something that we call secondary impact syndrome, right? So that can actually lead to lifelong issues, right? So if you have a child that plays sports, or if you yourself play sports, please do not take it lightly whether or not you may or may not have a concussion. And things that you should be looking for is if you have a fall, or let's say you had a car accident, right? If you find that your concentration has been thrown off, if you find that you can't really focus very well on things, you find that light is giving you trouble, if you find that loud noises are giving you issues, screen time when using your cell phone or your computer are giving you issues also, you find that you don't have as much energy, you want to sleep all the time. All those things are indicators in the event of some sort of traumatic injury that you may have a concussion. And, when it comes to having those concussions, well, the question is, well, what's the treatment, right? So for a mild or moderate level concussion, really time is your best friend, but there's a lot of things that you can do to help with that recovery. So cutting back on screen time, especially with cell phones and computers. For whatever reason, the studies don't really show a correlation with screen time with TV, so you can still watch TV if you have a concussion. But cell phones and computers, you definitely want to cut that out, or at least dim the screen on the computer and the cell phones, if you have to use them. Carbohydrates, the brain loves carbohydrates, right? I mean, we talked about, diabetic ulcers and diabetic neuropathy, and the reason why you have that is because the nervous system doesn't really have a great way of filtering out sugar, right, or carbohydrates, essentially. So if you eat healthy carbs, that actually can help with your recovery after having a concussion. Omega-3 fatty acids, we don't really know very well why it works this way, but it tends to have an anti-inflammatory effect to the nerves that got injured with the concussion. So omega-3 fatty acids can be helpful, fish oil, etc. And rest, drinking a lot of fluids, and also something called subthreshold exercise, which is essentially where you can just get out, take a walk, right? Get out, maybe do a light jog, as long as it's not making your headache worse or any of your symptoms worse. If you don't feel symptomatic when you're doing it, that's what we mean subthreshold. So below the level that can cause symptoms, exercise that can help with your recovery so you can get back sooner. But again, if you have a kid that participates in sports, and let's say they had an injury that you actually witnessed, but they're not necessarily telling you whether or not, you know, they feel different than they did before the injury, definitely ask some of those questions. You know, see how they're doing in terms of their concentration, how they're doing in terms of whether or not they have a headache, because that does become very important, especially in some sports that you may have not thought of, right? So, you know, girls soccer tend to have the highest rate between 9 and 18.
Thank you, Doc. Dr. Bennett Omalu was the Nigerian-born physician Nigerian-American physician who was instrumental in that whole diagnosis of CTE. And this can only be diagnosed in patients after they die, because you have to look at the brain post-mortem and see the effects of it. And that's usually because of multiple concussions, and there was a whole big class action lawsuit in the NFL regarding that. So another Black history fact, the movie Concussions with Will Smith acting in it, it's based on a true story, very informative. I mean, and this doctor actually still weighs in till this day on podcasts. And I think I forgot which play it was early in the season. Some podcast had him on, and he said, if I was that person's coach, I would never let him play, at minimum, not play the rest of the season, or he may just need to step away from football altogether. But unfortunately, a lot of young men, this is an outlet for them. It's a life dream to play in the NFL, and many times they take these hits, and unfortunately, you don't realize its effects until it's way too late. We have a few more questions before we open up the floor for questions. Dr. Martinez, women's health, how do you address mental health concerns with female patients? Speaking postpartum, anything else? How do you address that with your patients?
So there's such a high prevalence of mental health, especially in the postpartum setting, after you've had a baby. So it is a standard that we screen all of our patients, all of our pregnant patients, from the time they become pregnant, and then increase that screening after they deliver. So we have a set standard questions that we go through to weigh in on how the patient is doing and how she's feeling. And a lot of times, the patient may not even realize that they are being affected in a way that is where their mental health is not at their best. So whether it's anxiety or depression, postpartum depression, it's not until they get these questions asked, whether they read it or they answer it out loud, that they realize that something is going on. Once we identify a problem, the best things, we will talk about it with the patient, but that is not a diagnosis that we are heavily trained on. And so outside of your own, I continuously learn about this mental health space, but the best is to send them to a behavioral therapist, at least to start. Psychiatrists are I don't know if anyone's ever tried to see a psychiatrist. You basically can't get in. It is so hard to get into a psychiatrist, and personally, the experiences that my patients have had, because they are so full, they also don't have a lot of time to spend with them. So that, if a patient needs a psychiatrist, having that behavioral therapist is so key, because talk therapy, group therapy, medications can be recommended, checking in and keeping that line of communication open with the patient is the most important.
Yeah, and you talk about different specialties and subspecialties. That's important because a lot of us come from the Caribbean or other countries where medical care, even though the doctors may be highly qualified, we don't have as many categories or specialties as we have here in the United States. And the beautiful thing about specialties, you can get someone who has spent 3 years doing fellowships, studying athletes, for example, and how they respond to different treatment modalities, and then also how to treat injuries. And just knowing that you can find a specialist in a different area is very, very important. So I'll have a couple more questions, and then we'll open up the mic for questions. Dr. Gittens, plantar fasciitis, a very common one. I can attest that I've had it several times. Like I said earlier, you got me some orthotics. I kind of put them away for a while, thought I was good. Past 2 weeks, man, let me tell you. I was almost asked to bring a shot for me here in the parking lot today. But I actually put them on this past week. My wife can tell, I found them, I was like, oh, here they are. There was in like another boot. I put them in my shoe, and they're like glasses. They don't work if you don't wear them. So could you tell us what plantar fasciitis is, and some treatment modalities, and tell us how you can self-diagnose it?
Plantar fasciitis is inflammation of a ligament that inserts to the bottom of the heel. Primarily tends to be more so at the insertion on the heel, but it really can be the length of the plantar fascia itself. And it happens over time because the plantar fascia becomes basically overstretched, right? It becomes overworked, overstretched, and you develop inflammation. As he mentioned, itis is inflammation, right? And so it's a chronic thing that we see. A lot of it has to, we generally tend to see why someone may develop an acute plantar fasciitis is because either because again, shoe wear, so that's like a common thing you see that I keep coming back to, right? That makes such a big difference in regards to things. But the shoes that we may be wearing that just may not be giving us enough support, increase in activity, right? Or so common scenarios may be, I'm trying to exercise now, doc, but my heel is killing me, but they're using an old sneaker that likely doesn't have great support anymore. Another common scenario can be, it's summertime and, I'm using more flip-flops. My heel is killing me again, and again, now there are supportive flip-flops again, but I'm talking about flip-flops that tend to be more flexible, that tend to be very thin, or doing any type of increase of activity, maybe a shoe that isn't that supportive, but you do more activity. You go walking in New York City for the day and you just weren't wearing the right shoes, and a couple days later, you start to notice. So, what happens is the plantar fascia overstretch and it tightens, and it's basically an imbalance within the plantar fascia. And so you see it, you see it in athletes, you see it in common every day. I mean, it's one of the most common things that I treat daily in the office. And it definitely is manageable, right? So first two things that I always tell patients, that comes back to everything I keep saying in regards to elimination of barefoot walking, to removing shoes that are not supportive. So I tell patients all the time, if your shoes are very flexible, if you can bend them in half, it's allowing your plantar fascia to continue to overstretch. And so you have to give yourself more support. And then there's other things, again, depending on the severity of what we may or may not do, right? Stretching exercises may be something that they need to use. Yes, we use steroidal injections at times for it, yes. Also needing to increase the level of arch support. That may include orthotics, as Clyde has mentioned, right? And I tell patients orthotics are glasses for the feet. They're an insole that goes into your shoe. They don't change your foot, right? Glasses don't change your eyes, but they help to basically balance an imbalance in your foot. And so, sometimes we have to utilize other modalities such as physical therapy, and there's other, things that can be utilized for plantar fasciitis, but most patients do respond to the first four things, as I mentioned, in regards to shoe wear, stretching, support, shoe wear, injections, and then an orthotics. Normally, it's kind of like that last step of trying to prevent it from coming back and just giving the foot that support that it needs. You do, yes, tend to see it more in people who have flat feet, but yes, you can also see it in someone who has a high arch foot, right? That plantar fascia is being strained in regards to that. So it is something that anyone can develop, in regards to based on level of shoe wear and activity, but it definitely is manageable, and if you are having heel pain, it's not something you have to live with. Right? And of course, one of the classic things patients will say, those first couple of steps when I get out of bed in the morning, I'm in so much pain. If you're experiencing that, that's not normal. So you should seek, to have that treated, because the earlier you start treatment, the better statistically you are in regards to resolving this. Yeah.
In fact, one of the quotes I heard when I was in med school was, pain is God's gift to man. If you experience pain, there's a problem, to seek treatment. And that's what goes back before where we said neuropathy, where you can't feel pain, you can't feel that nail or that thumbtack in the shoe. As a diabetic, you don't know there's a problem until it's too late. So definitely you feel that pain, And I can attest, I've had it several times. Like I said, Jay's treated me. It literally feels like somebody's sticking a knife into your heel. And every step is like you're stepping on a knife. But definitely one of the more treatable ones. Last question, this will be for Dr. Desir before we get into our questions. This is a broad area. You told me you treat a lot of patients over 50 years old. Can you talk about sports injuries as it relates to the elderly, and perhaps probably chronic issues with arthritis?
Yeah, absolutely. So I'll actually go from each body part to each body part. So let's start off with the shoulders. What I tend to find, especially with patients 50 or older, especially when they're active, there's this group of muscles in your shoulders that helps you reach over your head, across your body, behind your back, called the rotator cuff tendons. All right, you have 4 of them in your body. And what I found is essentially with a lot of my pickleball athletes or individuals that are weekend warriors is that they do tend to get injured in their rotator cuff. They tend to, those activities tend to cause tears in their rotator cuff. Now with rotator cuff tears, there's 2 categories, right? So there's partial tears, where the tendon tears but it doesn't tear completely, and then there's complete tears, right? Where the tendon tears completely. But remember, you have 4 rotator cuff tendons. So any one of those 4 can tear, and just because one tears doesn't mean another one has to tear also, which actually opens up your treatment options. So usually in a younger athlete, you know, like a high-profile NBA player or a football player, you know, if they have a pretty big tear that's causing some issues, sometimes they have these tears called high-grade partial tear, where a lot of the tendon has been torn, but it hasn't completely been torn. Probably has to be fixed, but they want to play the rest of the season. So what we'll do in that scenario is do a lot of conservative management, short of surgery, try to get them through the season, and then surgery, because they're a high-level athlete that need their shoulder. And someone 50 plus, you don't always have to resolve your rotator cuff tears with surgery, even if it's a complete tear. A lot of times we can get patients back to normal clinical function, even though the tear is still there. There's a whole bevy of different options of what you can do. I'm a big believer in physical therapy, so I do believe that whatever your treatment is, even if you have surgery, what do you do after surgery? Rehab, right? So physical therapy should always be a part of that treatment, where you're trying to get rid of the imbalances. You mentioned imbalance with the plantar fasciitis. So to get rid of the imbalances in that shoulder, and also all the other muscles that are connected to the shoulder. So making sure your neck and your upper back are also in balance, also to prevent further injury. So for a lot of those patients, physical therapy for at least 6 to 8 weeks or so tends to help give them enough time to get that balance. Also, there's different injection options. We've mentioned steroid injections multiple times this afternoon. You know, steroid injections are good anti-inflammatories, but it doesn't come without any risk, right? So, you know, I mentioned earlier about if you're diabetic, it can raise your blood sugar. But also, if you're doing too many injections of steroids into the same body part, it actually can make things worse, right? So it can decrease tendon integrity when we're talking about the rotator cuff. If you're injecting into a joint, it can break down cartilage, so it can accelerate the progression of arthritis for people. So you don't really want to do steroid injections too much. You know, you want to save that for a rainy day when you're excruciating pain, nothing's helping, you need something in that day. If it's safe, then the doctor can do that injection for you. There's a whole other category of injections that are actually better in the long term. We actually categorize them as orthobiologic injections. I don't know if anyone here has heard of PRP, or platelet-rich plasma, which is essentially an injection where we actually draw some of your blood. We put it into a machine called a centrifuge, which is a machine that just spins very fast to separate out a lot of growth factors and healing factors from plasma that we need to re-inject into where the injury is. And, you know, a lot of times there's a misnomer to where these are categorized as regenerative treatments. We haven't really been seeing it reverse the injuries much, but what we have been seeing is that it does strengthen up the integrity of whatever structure you're injecting, so the tendons become stronger, which actually can help with your clinical symptoms. And a lot of times, I would say about 60 to 70% of people find relief with those injections. And when you find that relief, it usually lasts for at least 6 months. Many patients get years of relief out of it. So it does become a good option in conjunction with physical therapy to try to help. So with a lot of my patients over the age of 50 that don't want to go through a rehab after surgery, and really because they're not really living, you know, they're not high-profile athletes, they don't really need the surgery. You know, a lot of times what we'll try to do is exhaust those conservative options of physical therapy, plus or minus a cortisone injection if it's absolutely needed. And then, you know, if the insurance will cover it, or if, you know, the patient doesn't mind coming out of pocket, we can apply some of those orthobiologic injections. Stem cells, I'm sure many of us have heard of stem cells. We even just spoke about Henrietta Lacks. There's different types of stem cells that we can actually use from your body. There's bone marrow derived stem cells where we actually can get some of the bone marrow out of your pelvis. We put it into a very similar machine to pull out a lot of the same growth factors and healing factors from the PRP, but in addition to those factors, we also get stem cells. With those stem cells, there's medical terms here that I'm going to throw out. I'll try to explain it so everybody understands it. But these are things called mesenchymal cells, which are just a fancy word for stem cells, which actually they have the ability to proliferate or turn into a whole bunch of different types of tissues in your body, right? So the theory behind it is that if we inject that into an area in your body, it can help repair. Again, we haven't really been seeing the reversal of the injuries, but it does strengthen up at a microscopic level what's going on in the tendon, so that can help. So rotator cuff injury in the shoulder, also arthritis in the shoulder, very common. So obviously the shoulder is a joint, and when you have a joint, that's two bones that are right next to each other, right? And the way that you protect each other, the way that you protect the bones from each other is with the lining of something called cartilage, right? So the cartilage protects the bone to avoid any continued degeneration or breakdown of the bone. Well, over time, that cartilage wears out. It's just like a tire, right? You buy a new tire, you're using your car, that tire is going to wear out eventually. And over time, when that cartilage wears out, it exposes the bone. When the bone rubs against each other, it can cause a lot of inflammation, which causes pain. So things like cortisone injections to decrease the inflammation can help. Also, these orthobiologic injections can help strengthen up the surface of the bones to help the bones take more of the wear and tear from everyday life, so you're not getting as much inflammation, as much pain. And again, I would always couple those things with some physical therapy. I'll try to be quick. So you go down to the knees, right? So with the knees, arthritis, same concept as the shoulder, right? It's a joint, cartilage can wear down, the bones rub against each other, causing inflammation and pain. All of those injection options in physical therapy are also available for the knees. Also, many of you may have heard of something called the meniscus tear. So the meniscus, there's two menisci in each knee. One is on the medial aspect, which is the inner portion of the knee. One's on the lateral, which is the outer portion of the knee. And they're both two C-shaped pieces of cartilage that act as the shock absorber of the knee. So the knee takes on a lot of wear and tear throughout a day, whether it's walking, whether it's going from a sitting to standing position, whether you run, things of that nature. So that meniscus can tear. Meniscus tears, especially in older patients, tend to be they can be a little complicated to treat because the meniscus itself doesn't have a great blood supply depending on how deep the tear is. So depending on the meniscus tear, you can't just go in there and fix the meniscus tear, right? A lot of times what we end up doing is we try a lot of conservative options, similar to what I spoke about in the shoulder, to see if patients can get better. If they can't, a lot of times what has to happen is a piece of that meniscus has to get cut out, something called a meniscectomy, which does help relieve pain, but again, the meniscus has a function. It's the shock absorber of the knee. You cut out a piece of the shock absorber, over time that's going to accelerate the development of arthritis, which down the line for our elderly patients, you do have the option of a knee replacement. All right, and a knee replacement is really just a joint resurfacing. So you're not replacing the entire bone in your lower leg or your thigh. All you're doing is replacing the surface of the joint with an artificial metal, which actually helps remove the issue of the bones rubbing against each other. No inflammation, no pain. But even after the surgery, rehab with physical therapy, which should always be part of your treatment plan. Last thing I'll touch on is lower back pain. So I'm sure there's a lot of people that deal with that. It can be related to arthritis. It can be related to a disc that may have slipped out of place in between each individual vertebra or bone in the spine. You have a disc there that does the same thing that the meniscus does for the knee. It's the shock absorber for the spine. So when that slips out of place, that can cause a muscular imbalance in the spine, which can cause spasms and pain. It also can pinch on a nerve, which can cause pain shooting down your legs. So anytime you have an electrical shock-like pain, or pins and needles, or numbness, or burning going down the leg, even though you think it's coming from your leg, there's a strong possibility it may be coming from your lower back. Same thing applies to if you feel those symptoms going down your arm, it may be coming from your neck. Also, there's something called a disc herniation, where the outer portion of the disc tears. So the contents from inside the disc can shoot out and push on a nerve and cause similar symptoms. Physical therapy should always be a part of the treatment there also, but if the nerve is getting pinched so much so that it's causing weakness and you're losing the ability to walk or use your arms or things of that nature, that's when you should definitely have your doctor refer you to an orthopedic spine surgeon or a neurosurgeon for a little bit more aggressive intervention.
All right, thank you, Dr. Desir. That's why I left that question for last, because I know that's, we talked about it, and that's a very, very huge component of our older population, arthritis, or even, not necessarily older, but if you're an athlete and you've had years of pounding your knees, like Kobe Bryant, he definitely had some of those symptoms, even though he stopped playing when he was like 37 or 38. All right, so we have a mic set up there. If anyone has questions, remember, we have specialists here. We have a podiatrist, sports medicine physician, and an OBGYN. So there's also a way you can scan to ask a question. I think this is more so for the folks in the chat. But yeah, anyone has any questions related to these three fields? Mr. Wiseman, you can get the mic. 1 second, sir. You're next.
I have a question about the heels. If you wear heels for a long, long time, do it eventually affect your knees?
Absolutely. I mean, I'm sure he can speak in regards to it, but right, as Clyde mentioned, our feet, right, are attached to the rest of our body. And so any type of imbalance, right, that shifts the way that weight is distributed in our feet can inherently affect other parts of our body, right? It can affect your knees, it can affect your back, it can affect your hips. So the answer is yes, right? And so, I always say to patients when they come in, especially I find sometimes in my population of women who are starting to get a bit older and realizing that they can't wear the same shoes. I said, no woman ever looks at, you see older women and they're wearing certain shoes, and I don't think people go, I can't wait to get to those shoes, but it's truly just the accommodation of what your body can and can't tolerate as we get older. The shoes that you might, and heels you might have been able to wear in your 20s and 30s, you likely can't wear in your 40s and 50s, and you feel it, right? You know in regards to how it affects your body. It's not just your feet, so the answer is absolutely yes.
Good question. Says any other? Yes, there's a gentleman back there. And please speak into the mic so the folks online can actually hear you as well. Yeah, it's on. Just tilt it up.
Yes, good evening.
Evening.
There is a subject I was waiting for, but I don't get it. It's about a prostate cancer. This subject is allowed. So my question to you, how can you prevent a prostate cancer, and how can you treat also a prostate cancer? Thank you.
So prostate cancer is it's similar to breast cancer. Highly, there's a high proportion of it in our black community. In terms of one of the best way you can actually treat it is one of the first things you want to make sure you're getting yearly screenings. Annual screenings at 40 years or older. However, if you have a history of it in your family, you want to actually start the screenings early. In fact, the doctors will recommend that. Personal story, my dad actually had prostate cancer. Thankfully, it was detected very early, and he went with the most aggressive, had it taken out. So it was because it was seated all the way in the middle. So he took it out early, so he never had that again come back. Obviously, my story, it didn't metastasize anywhere else, is what I'm saying. So because of that, my doctors actually do what's called it's actually blood work. So I know as Caribbean island men, we feel tough, like, no, there's no way nobody's doing that digital rectal exam on me. But you have to do what you have to do to make sure you get screened. But there's blood work. There's a blood test. It's called a PSA, the prosthetic antigen test. I get it done annually. It's blood work. They look for it in the blood, and if there's an antigen in the blood, it tells you. Thankfully, I'm in my early 40s now, and it's been good. But I've been having it done since my 30s because of my history. And this is why when you go to doctors, it's important to tell them your whole history. Tell them your family history. You know, I am a product of a Caribbean father, and I know a lot of time my mom's in the audience can tell you a lot of times, oh, everything's good, it's good, but many times it's not. So when you get into the room with the doctor, you ask questions. And one of the things I've seen, and you guys probably seen in your practice, they will see, a patient will see the medical assistant and give them a little bit of information. When the doctor comes in and asks, now they'll give the rest of the story. And that's why I started this segment where the doctors kind of introduce themselves and tell them who they are, because that personal relationship, the bedside manner helps, because it also helps that relationship. In terms of to prevent, we don't have any specialists up here for that, but definitely one of the biggest things we always admonish our patients, nutrition. Because there are several factors that affect cancer, right? There's genetics, which is who you are, your genetics, your makeup, what product of environment, and that includes diet, right? So you may want to look at your diet. Diet's high in meat. In fact, when we talk about blue zones, if anybody's familiar with blue zones are spaces on the planet where there are people living well into their 90s, late 80s, 90s, even up to 100, large populations of those folks. And vegetarians happen to be one of them. Parts of Asia happens to be one of them, especially in Japan. So we want to make sure that we're having the right diet. That's key. And one of the blue zones actually is in Loma Linda, California, where is one of those seeding grounds of Adventism where the vegetarian diet happens to actually help in a lot of aspects of life. Again, doesn't mean you're not going to get it, because there are vegetarians obviously who get cancer, but you want to screen as early as possible and as often as recommended. The same applies to colon cancer, 45 and older, get those screenings every 5 years. If there's an indication that you need it more often than that, your doctor will tell you.
Just to piggyback on everything he said, first of all, everything that he just said is right on point. I just want to reemphasize how important it is to make sure you go to your annual doctor visits, all right? So, because a lot of these diseases, like you said, if you catch the prostate cancer early on in the process, is a very treatable cancer. You know, in the medical world, what we know is if you have prostate cancer and it's caught early enough and treated, you're probably going to die from something else, right? Not the prostate cancer. So, you know, it's something that responds very well to treatments, whether you want to cut out the entire prostate or undergo different types of, you know, radiation therapies or chemotherapies, et cetera. It's very, very easily treated. I've had family members of my own that have been diagnosed with it that were treated and they're cancer-free, right? You know, it's well known throughout the medical community that if you're catching these cancers on, well, this cancer in particular on time, you know, it's very easily treatable, and again, you more than likely are going to survive, and if you pass away, it's going to be from something different, all right? So I just want to emphasize the point of making sure that you are getting your screening, because with something like the prostate, you know, there's a lot of colleges that don't necessarily recommend it as something that you should just be screening regularly for. But if you have that family history, which, you know, a lot of it's Black History Month, right? So a lot of individuals in, you know, those populations do have that family history or have a higher risk of developing prostate cancer. So you should be speaking to your doctor about these type of screenings, because again, even if you develop that cancer, this is one of those cancers that should not be the reason why someone passes away.
Any other questions?
Yes. So my question is like in threefold. Is diabetes reversible? If so, how can you reverse diabetes? And also, does medication control or reverse diabetes?
All right, so I'll be brief. All right, so yeah, there's different types of diabetes, right? So there's type 1 diabetes, type 2 diabetes. You know, anyone on this panel can correct me if I'm wrong. Type 2 diabetes is something that could be reversed, right? With things like diet and exercise. Obviously, if your A1C is very high, you're very symptomatic, your blood sugars aren't very well controlled, you've tried, you know, diet and exercise, that's not working, there is value to, you know, adding medications, right, to help normalize those blood sugars. But, you know, with type 2 diabetes, if you're able to get to a point where you eventually could get weaned off those medications, so slowly taking off those medications so you can get to a point where you don't need them anymore, it is very possible with type 2 diabetes. Type 1 is a little different. Type 1 is diagnosed, you know, earlier on in life. And with type 1, typically those patients do tend to have to be on medications. I haven't really seen any cases in my experience. I'm sure there maybe is some out there, but I haven't really seen any in my experience where patients were able to, just with diet and exercise, get off of all their medications in type 1 diabetics. But type 2, definitely. And it's not just medication, not just diet and exercise. There are some patients that do look into surgical options also that tend to, bariatric surgeons or bariatric surgery, that actually tends to help resolve type 2 diabetes in patients also.
I just want to say one other thing. So absolutely, in regards to everything he said, the only other thing I'll add is I always understand in regards to patients who are type 2 diabetics, and it absolutely can be managed, again, without medication. But really, in essence, once you're a diabetic, you're always a diabetic, meaning that you're just a diabetic that's controlled, right, without meds. So, you know, and it can be done. I have patients, I have seen in regards to it, but, you know, you just have to be very diligent in your diet and you know, exercise things. And there are some patients, just also of understanding that there are patients that maybe eat well and they may do certain things, but their numbers still aren't at a point where they can go without medications. And that's at the point where, you know, you have those conversations with your doctors in regards to it and deciding, is it time to go onto those medications, right? Because a lot of times, you know, in certain circumstances, if you're going for your annual exams, right, that's one of the things they're checking, and they're checking to see, and your numbers may be starting to trend up, and that's where you're trying to see if you can avoid getting onto the medications. But if you're not able to control it, you have to use, these medications are there to help, again, in regards to that. So we would love for patients to be able to control their diabetes without medications. But in some circumstances, they cannot, and that's where, you know, again, the conversation about what kind of medications and different things like that might be appropriate at that point to start.
So the beautiful thing about, like what we talk about in terms of specialists, it's important to consult with every facet of your medical care. For example, the nutritionist will be able to help. There's a movie that I saw some years ago. It's called Simply Raw. It's probably like you notice there's a theme with all these movies I recommend. I tend to like these. It was actually a documentary called Simply Raw, where they took about 12 or 14 diabetics, including 2 type 1 diabetics, uncontrolled diabetes, gave them a 90-day raw diet, raw foods, meaning everything they ate was raw, vegetables, fruits, nuts, grains. After those 90 days, including one of the type 1 diabetics who came in with a 1,200 glucose level, 11 of those 12 were actually controlled. The one who was not controlled was type 1 and found out that his friend, they took them to Arizona, was sneaking in alcohol to him on the camp. So, can it be done? Yes. However, it'll take a concerted effort. Because remember, especially if you're type 1 diabetic, those patients, diabetes happens when you have increased blood glucose. Insulin is produced by the pancreas or the islet of Langerhans in the pancreas. Those cells actually help secrete insulin to lower your blood glucose levels. In type 1 diabetics, they have no production, little to no production at all. And they definitely need insulin, and sometimes in conjunction with other oral medications. Now, one of the other things that is an issue with diabetes is something called truncal obesity. So when you look at, because they've found patients who may not be overweight, but the belly fat around their midsection, for some reason, that belly fat is there as a result of the increase in another hormone, cortisol. And that cortisol, as it increases belly fat, actually has a counteraction to the blood glucose, causing it to spike. Now, in some cases, cortisol is good. In stress, you may need it to be able to function. But cortisol over a long, extended period of time can actually lead to those issues of belly fat being added there and lessening the impact of the pancreas and the secretion of the islets of Langerhans. Of insulin from the islets of Langerhans cells. Now, again, just doubling back to your question, anytime we have forums like this, it's important that you always consult your doctor. But if there's a person who has diabetes, especially type 2 diabetes, and you feel that, man, these medications, because they take a toll. Some of them, the side effects can cause a lot of issues. It's important to say, hey, can I speak to a nutritionist and find a nutritionist to see if they can help? I'm not saying to stop any foods or diets or medications cold turkey, because that can cause, more issues. But you definitely want to have a conjunctive approach to this issue. So yes, it can be done. I suggest if you can find that. It's called Simply Raw. Take a look at it, and they actually fed them. These patients, they took them from all walks of life. Poor, middle class, they took them, white, black, and that was what they found. In fact, just one other thing, there's actually I've been seeing it quite recently. They're also looking at the problems not only in the bloodstream of type 2 diabetes. In fact, now they've been calling dementia type 3 diabetes, where they feel like early onset dementia is actually related to diabetes or diabetic patients. So it's not quite a medical norm, but they've been calling it the type 3. So patients, if you know family members who may be having symptoms of dementia early, a lot of times that may be caused by being diabetic for extended periods of time. So it's definitely a disease that disproportionately affects our community, and we definitely want to get a handle on that. You got a follow-up question, brother?
So what I understand from this is that medication is only used as a control. It will not cure. It will not reverse.
It's not a cure. So, like I said, there are different types of medications. There's the secretagogues that want to help you produce more insulin. There are those that actually help lower it. There are those that help you actually, there's one they're pushing now, I'm not even going to say the name, that's helping you lose body weight. And it's becoming like a fad, and people are getting sick or dying from it. So we have to make sure that anytime you have these conversations with your doctor, have a very frank and candid conversation and say, listen, if this is how you feel, I know this is what's going on, and I know I may need this to help control my blood glucose, but can I get a consult with a nutritionist so I can see how I can best help my situation? And that nutritionist dietitian, they have a different perspective. They have done all these studies. Because remember, when we talk about specialists, no one doctor knows everything, and there's a reason why we try to bring different specialists up here, and I think in the future we'll definitely bring in some more. But we want to make sure that you get a very, how should I put it? It should be a full frontal approach to attacking a disease. So it should not be, well, I'm diabetic, I'm taking 4 pills for the rest of my life. Ask questions. And sometimes do research to go ask your doctors. There's something on Google called Google Scholar. You type in Google Scholar, and it pulls up a whole different Google, where you find articles that are actually peer-reviewed medical studies. So, when you pull Google, there's a lot of nonsense you got to shift through. You go into the Google Scholar background, it actually pulls you up full journal articles. Some you got to pay for, but most times they're free, and you can actually read and educate yourself. You educate yourself on that disease, because when you go to that doctor, you should be the expert on you. He's or she's the expert on the disease and the treatment, but you should be able to say, hey, at this time of day I feel a certain way. When I eat certain things, this is what happens. You're testing your blood sugar 5-6 times a day. You should be the expert on you, and all you're going there for is to get that 1, prescription, or 2, that advice, the medical advice, or 3, the referral if you need it. Because remember, you don't go there every day. You live with diabetes every day. That particular person treats you 2 or 3 times a year. Any other questions? Sure.
So, my question is, I have flat feet, and usually I try and wear sneakers that'll have support, but sometimes if I walk for too long or I just stand for too long, my feet start to go numb. So is there anything else I can do about that?
Well, yes. So, if you're having continued pain, again, pain right? Your feet, a lot of times, I get referrals from pediatricians and primary cares a lot, right? Because sometimes the pain is not in their feet, they're having pain elsewhere, but they recognize that the imbalance, right, that abnormality, that flattening out of the arch is affecting the rest of what's going on with the body. So a lot of times you may need some type of orthotic or insole that would go into your shoe that would help to give you more support in that arch area. It depends on the severity of the flat foot. It depends on, is it more flexible? Is it more loose? Is it more rigid? Sometimes x-rays need to be taken to see, so it's a workup that needs to happen in regards to it. But, if you're making modifications as suggested and the pain is still there, then you should absolutely see a podiatrist.
Back to the heels. I have 3 questions related to that, and then one that's like any of you can answer. Can you give a ballpark or an average amount of time that you would recommend for a female to wear or stop wearing heels? Is there a relationship between pinched nerve, maybe in the neck, and herniated discs and wearing heels? And also, are these things like permanent issues or can they be fixed? And the other thing is there such a thing as differential diagnosis?
Yes.
Differential diagnosis.
Okay, so I'm gonna let you answer 2. She's asking about the pinched nerve and all that. I'll comment and you can add anything. Oh, sorry. Uggs. So again, Uggs are a common type of shoe that a lot of women wear. They do not offer a lot of support. So yes, they can influence foot problems. Again, I'm not anti-Uggs, but Uggs should not be an everyday primary shoe. It just doesn't offer the support that we need. It can be, so my answer to that is that yes, Uggs can cause some patients to have pain. Now, again, I always answer these questions to people because yes, there are some people that can wear certain shoes and they don't have pain, but everyone's feet is different. And so if you're noticing that you're having pain with, daily use of Uggs, and you should need to readjust your shoe wear or be mindful of how much time that you're utilizing them for. So the second question you mentioned in regards to could heels affect the pinched nerve? The answer is yes. Again, a heel shifts the way that weight is distributed in regards to the bottom of our feet, right? Our feet are designed to absorb and to take, the way that we absorb weight in regards to our heels, to our forefoot, to our toes. And so when we're shifting that, there is a process that happens with the rest of the body, again, where the knees can be affected, the hips, the back, could cause anything up until leading up into the neck in regards to those symptoms. And a differential diagnosis, so there is a such thing as a differential diagnosis, but I'm not sure if I think you asked, is there a such thing as a differential diagnosis? So absolutely, when, in regards to how it applies in regards to when I'm seeing a patient is when a patient's coming in and they're presenting with pain or they're presenting with a situation, there may be an initial differential diagnosis that I may initially have in regards to what that could be. And so part of that workup is trying to assess to figure out what diagnosis it is. Sometimes you may be able to assess that initially and be able to kind of rule out certain things. And certain things require more of a workup of either, additional testing in order to be able to differentiate. A lot of conditions can have overlapping symptoms, right? And so that's where that differential diagnosis comes in regards to trying to assess and to figure out what it may specifically be and sometimes in certain things, it may seem as something at one point and you're having to reevaluate to see how the patient is doing to be able to really assess, is that diagnosis still correct in regards to, in regards to how the patient is improving or not. So that's it. I don't know if you have anything else to add.
No, you answered that great. I would say, you definitely could have a herniated disc secondary to the imbalance, right? So just imagine, think about how you're standing in a heel, right? So imagine you remove those heels and you try to walk in that same way, so you'd basically be walking on your tippy toes, all day, right? So the muscular imbalances that can develop from that type of gait can lead to, going all the way up the entire posterior chain to where it can affect the lower back, it can affect the mid-back, it can affect the upper back, which can increase the likelihood of developing an injury, right? So whenever you have muscular imbalances, those muscles aren't protecting the joints as well as they naturally should be, which can increase your likelihood of developing things like a herniation. I'm not sure if maybe what you were alluding to was if you're feeling numbness and tingling from as being someone that wears heels. Yes, there is a differential diagnosis for that. Herniated disc isn't the only thing that can cause, nerve impingement, right? Especially if you're in a heel where you're in that flexed position. That sometimes people have a bone in the back of their heel that hasn't fully fused, right? And it can actually cause some irritation to one of the nerves that passes through the foot there. Sometimes you can have an extra bony growth in the back of the heel that can irritate your Achilles. It's a lot of different things that are on your differential. And like she was saying, there's a lot of different things that we have in terms of diagnostic tools that we can use to hone in that differential diagnosis to come to an actual diagnosis.
So I just want to be fair in the interest of time. We actually have 4 questions in the chat. I want to get to these for parity's sake. This is a good one for Dr. Martinez. There was no mention of HPV as a risk factor for cervical cancer and the role of the HPV vaccine. Can you speak to that?
Okay, so cervical cancer, there's different cell types of cervical cancer, and the most common cervical cancer is caused by HPV. HPV is a virus that is transmitted from person to person through contact. And it can live in the genital area. There's strains of HPV that can live in the throat. There's different areas, but mainly in the genital area. So touching that area, that virus can be given to one person or the other. The HPV vaccine is something that can actually disappear on its own, especially if you are younger and healthier. But with time, it may not, or simply just because luck of the draw, it may not. So the HPV vaccine is recommended in both men and women, or boys and girls, for girls starting as early as age 9 technically. So 9 through 12 it can start. And it's FDA approved and now covered by insurance up to age 45. So the idea is, if HPV is the most common cause of cervical cancer, there are several strains, and if we can prevent the most common, now it's 9 strains that you could possibly get, then we can decrease your risk of cervical cancer. So that is where HPV comes into play. Now, this was something that I also thought about before. You can have a normal pap smear, you cannot have HPV, and I've had patients with this, and then still get cervical cancer. Like, I've seen it 1 to 2 years after a normal pap smear, because there are different types of cervical cancer. And we don't know how to screen for the other types yet, right? So you can do your pap smears, you don't have what we call squamous cell cancer, and next year adenocarcinoma can show up. So that is something to keep in mind.
Thank you. The question here, can you stop taking blood pressure medication after it's under control, or do you need to still take it to maintain it? Take a crack at it, or you want me to take a crack at it?
Yeah, I would say, let's say the blood pressure medications was actually keeping the blood pressure under control. You'd have to go through a trial of having your provider safely try to wean you off the medication, and also build a plan, right, and how you're going to control it through other means like diet and exercise. To safely see if you can remove that medication completely. I wouldn't stop it cold turkey, especially if it turns out that the medication is the reason why your blood pressure is under control. I'll give a quick story. I had a friend of mine who, back when I was in medical school, so I didn't really know as much as I know now, but I know a little something just from the studies that we had to do. And his mom was diagnosed with high blood pressure, and It was, pretty severe blood pressure. The doctors recommended some medications. He told me that, nope, we're going to do it through just natural medications, natural treatments, and things of that nature. I hate medications. I hate doctors. We're not doing it. And, unfortunately, about, I would say 4 or 5 years later, he called me to pray for his mom because she had a stroke, right? And, stroke is one of those complications that can come from poorly controlled blood pressure over time. So if you want to get off of the medication, it is possible. Just make sure you're working together with your physician to come up with a plan. You mentioned nutritionists. There's a whole team that you can get on board to make sure that we can come up with a plan to make sure that you can safely wean yourself off of those medications. If the weaning process renders inefficient and you have to get back on the medications, that just becomes the unfortunate reality.
And that's the benefit of adjunctive care, which is you have to make sure a lot of these medications obviously are synthetic and they may have some side effects. That's why when you see them on the ads on the TV, they put it in fine print, they rattle it through real quick. However, if something is needed to keep you from becoming debilitated or from dying, that's where you make the effort or the choice. Okay, if you know that you were an athlete when you were younger, I'm just giving an example. You were an athlete when you were younger, there's no history of high blood pressure in your family, now here you are 20 years later in your 40s, and you're overweight, and it only happened when you notice you gained weight, well, you may need to take that medication, but remember what you did as an athlete to be in that tip-top shape, and go back and see if weight loss helps. And then you'll be surprised how a lot of times many of these conditions can be reversed. However, there are times where folks may have high blood pressure, and we may not know. In medicine, it's called idiopathic. In fact, I remember a cardiologist told me one day, he's like, "Doc, you know what idiopathic means?" I was like, "No." He's like, "It means we're idiots. We don't know what's causing it." And it's literally no sodium in the diet. The person seems fit as a fiddle, but their blood pressure is still up there. In some cases, until we figure out exactly what's going on, you need to take it for maintenance until you get to that point, like Dr. Desir said. There are 2 more questions, but I think one of them kind of answered. One asks, once you have high blood pressure, will you always have it? So again, it's similar to diabetes. It's one of those things where it's a silent killer. You want to make sure you take control of it. If there are ways to reverse it by diet, exercise, stopping alcohol use. In fact, a lot of times they say control alcohol use. But if you don't do any at all, do you really need it? Think about that. And the last question, I think, is a really good one. Family help. Any tips that can be given for getting island parents to listen to being told to go to the doctor, exercise, or change their diet? And I will let any or all of you answer that, and I'll give my 2 cents and we'll wrap up.
I literally have that question, and it would be for you because my father is a diabetic. It's his diabetes, so he knows better than anyone. I don't even know if he really believes I'm a doctor. He just doesn't listen to me. And I'll go to the endocrinologist, to the foot doctor, and I don't, do you have any advice for that? Because he knows best, and he wants his sugar at a certain level, because 120 is too low, right? And he does fairly well, but it's concerning for me because I know that that's not where he should be.
Yeah, it's one of those things. Again, I had one of those stubborn island fathers. It's just one of those things where you understand. They need to understand for themselves, but as a child or as I wouldn't say kid, but as their child, approach it with love. One of the reasons we brought doctors up here from our background is, I know Staten Island is a bit of a trek, but for me personally, now that I've kind of developed a relationship with Dr. Desir and I know him, if I have an issue, once my insurance is covered, I'm going to go see this brother. I personally go to a Haitian doctor. My wife can tell you, I complain all the time how long it takes to be seen. But I tell him, put me for the last appointment for the day, 6:45. I get there and I'm in the office, 7:30, I'm in the treatment room waiting. But one of the things, and people keep going back because he takes time with his patients. And I see a lot of elderly Haitian patients going there, and when I speak to the receptionist, like, why is this room always full and they got to wait all day? She said, listen, they love him, and he talks with them, and he has that relationship. I don't think I'm sure he knows my name and reads the chart. He calls me big guy. He always asks to my son when he comes. When I come into the room, I show him pictures of my son playing the drums. So he has that relationship with me. I'm not Haitian, but he's almost like a father figure type. So I find it hard after going to this particular group for like 20 years to pick up and go somewhere else, even though I'm always complaining how late I have to go. So maybe you should try and find someone in the community that can really relate to them. And hopefully that can help. But I think you have to approach it with love, talk to them from a standpoint of, you know, we want you to be around to see Christian go finish college and be able what he wants to be when he grows up. I want, you know, just how you took care of him when he was a baby, I want you to be able to see him and maybe hold his baby. You know, make it personal for them. Because I can definitely tell you, if you go the route, you have to go, they're going to put up a block. They'll stonewall you. I know it from personal experience. But you add the love aspect to it and see if you can find a practitioner who might be from the community who can help. All right? The time is way far spent. I want to thank our 3 panelists for being here today. I know there was a lot of questions for the general medical doctor, you know, to answer, and obviously because we're specialists, we do have a certain level of knowledge, and you know, one of the beautiful things about being as a doctor is knowing when to refer and when to defer, so we gave you those answers to the best of our knowledge, but we will definitely have more of these. You know, Dr. Reid couldn't be here today, but he is actually the Health Ministry's director, and he is a medical doctor, internist, and we actually had a conversation right before coming on here. I spoke with him. Unfortunately, he could not make it today, but we will definitely have some more of these where we'll, that's Dr. Reid, hospitalist, New York Presbyterian Weill Cornell Medical Center. Always wears a beautiful smile just like that. And he's like, again, Health Ministries Director, and he is always around here, and I will definitely parlay with him about having more of these sessions. And, you know, one of the other things, and lastly, before we close off, I know 10 minutes feature here earlier enough this morning, you heard Brother Sylvester do a piece on mental health. Definitely sorely needed. We need a whole panel of that, just mental health. We need a panel on just primary care diseases, because, and so, you know, they say Black History Month should be every month. Emphasis on health should be every month. So we'll be working behind the scenes to make sure, utilizing persons in our community, even in our audience, to make sure we have nurse practitioners in here who have specializations, and we will make sure we definitely have more of these sessions more frequently and make this a safe place for folks to come and ask questions either on the mic or in the chat. So that being said, thank you for the online participants for sending those questions in. Thank you for those who came out for here. I'll pray to close off, and I know there's a basketball game some people probably want to go see, so let's go. Dear Heavenly Father, we thank you for this day. We thank you for blessing us and protecting us and bringing us through another day and another week. We thank you, dear Heavenly Father, for imbuing your wisdom and knowledge on high to these physicians on the stage, dear Heavenly Father. We thank you for the participants in the audience, for giving them the ability to comprehend and ask challenging questions that would help them then go back and think and even speak to their practitioners about their conditions. Dear God, and those who did not get a chance to ask or were probably too shy to ask, we ask that you'll help them to have that ability to approach their health care with a new fervor. Those people who may be reluctant to go get screened for whatever conditions, dear Heavenly Father, we ask that they, hopefully after today, they would have had the ability to do so and the drive to go do it. We thank you again for taking us all home safely in Jesus' name. Amen. And lastly, before we go, again, Dr. Gittens-Hebron, if you want to put her slide up, she has a private practice in Somerset, New Jersey. If you ever have the ability, and if you have issues with, she's the owner of Premier Foot and Ankle Center in Somerset, New Jersey. Dr. Desir practices in Staten Island. I know that might be a little bit of a trek for some, but definitely she has a practice. Like I told you from personal experience, I've been there myself. So please don't hesitate. Hit her up, make an appointment, or go see Dr. Desir, and make sure you take care of yourself. And again, thank you for coming out.